Good evening, everyone. I'm Mohamed Masry, Assistant Professor at Department of Surgery, University of Pittsburgh, and the Chair of the WHS Education Committee, and I will be moderating today's webinar. And thank you all for attending the first of the WHS 2025 Fall Series, which is today's title is on AI Fundamentals for Wound Care Professionals. Please note if you have any questions throughout this evening's presentations, please utilize the Q&A box and we will address as many questions as possible at the end of the webinar. As a reminder, this webinar is being recorded. I will be moderating the session and with our esteemed two speakers, Doctors Jordon Gilmore and Lucian Vlad. And today's would be a little bit different than previous webinars. We used to have a part A and part B, but today's we will have a dialogue going through back and forth through the slides. And we will start with our speakers to introduce themselves. First by Dr. Jordon Gilmore to introduce himself. And I would like to invite Dr. Lucian Vlad to share the slides so we can start the webinar.
All right. Hello, everyone. I'm Dr. Jordon Gilmore. I'm an associate professor of bioengineering at Clemson University. I primarily study biosensor and novel biosensor applications for chronic wound healing, where we focus on electrochemical techniques and wholesale synthetic biology. I also have utilized applied AI techniques as well to build diagnostic and therapeutic tools in the lab as well.
Okay, can you hear me?
Yes.
Yes.
All right, I'm Dr. Vlad, and thanks for the invitation to present tonight. I would like to emphasize that I am presenting this webinar as a clinician. I am out there in the clinic seeing patients, and I'm trying to make sense of this interest in technology. And my hope is that this will help us be better providers and deliver better patient care. So I'm not a computer expert or a AI expert, and so it's possible that some people attend this webinar today and are experts. They're going to see that this maybe is going in maybe not the correct direction, and so I would really ask for those people's input to please correct us, help us go in the right direction. That's the purpose of this webinar. And this is meant to be as an introductory series and should be followed essentially later on by more specific topics. And we're looking for inputs for everybody, like what kind of topics would be of interest in exploring these interest technologies that we're using. So yeah, besides the disclosures that we've seen on the disclosure sites, I have this one more. The AI tools are not meant to do the work for us. And we're hoping that that's not the way we're going to use this. But they really should help us be more efficient, more productive. And so, we can focus more creativity. We're just hoping that these tools will do the nitty-gritty work so we can do the creative work for us. And yes, I've used two AI tools to work on this presentation, but I try to get one of these tools to do the presentation for me. It just doesn't work. You can use it to enhance your presentation. You can, help you get your ideas, enhance the visuals, but it just doesn't do the work for you. So we're going to dive a little bit into the history of this subject. The computers started making a way into our lives into the 50s and the 60s. And the term of artificial intelligence was coined at the Dartmouth conference in 1956. So, it's like 80 years ago. And then predictions of AI started coming into the 1980s. But although the scientists believed the machines would achieve human level intelligence within decades, this optimism about it just didn't pan out, and progress was a lot slower than anticipated. And this was limited by computing power, data availability, algorithmic sophistication were insufficient for the grand ambitions of the early pioneers. There were many AI winters. A program come up and they bring hope, and then investment would drop, and nobody will hear about those projects for a long time. So that's why we call these AI winters. But with the computing power revolution that we are seeing in the past couple of decades, things are changing. So the Intel co-founder, Gordon Moore, he's the one that made the observation that is now called Moore's law, that the exponential growth in a processing power, where the transistors that are present on the surface of a circuit doubles every 2 years. And that's kind of how things happen. So this has led to more powerful, smaller, cheap electronics. And this had driven this exponential growth of the technical innovation for decades. The specialized hardware advancements in computers, some of these GPUs and some of these processors were used for gaming laptops. And then transition into these, what we call now TPUs or AI chips, which are specific, and they're very, very efficient for very high machine workloads. And then everybody's heard about the cloud computing. So this is the availability to share data across fast internet and put all this together to create synergistic effects, really, really increasing the computing powers. We have a timeline here with some of these milestones, where before 2000 we had really very limited hardware capacity. AI was limited by that. In 2010, we're starting to see this processing revolution. And so now in the 2020s, just in the past 5 years or so, is what we call the democratization of the specialized chips and the cloud computings, which has driven a lot of this progress. There is truly a global AI market. This is not just for wound care or healthcare. And you can see these graphs, it's just in the past 5 years where we're seeing steady growth, and we're anticipating exponential growth in the next few years. And healthcare AI is about 15%, but this is the largest and the fastest growing segment. And investments are in the billions, 15 billions in 2023. If you look at the geographical distribution, North America is the current leader, has the largest share, estimated about 45%. And so this dominance is attributed to a very mature and digital healthcare infrastructures. There's a major technology and pharmaceutical companies, and there's a robust venture capital ecosystem in North America. And so investment in healthcare AI startups in North America reached 8.2 billion in 2023, as I mentioned before. There is a strong investor confidence the past few years. And this is also the pathway for FDA has been sort of established already by the FDA, and these are crucial for AI adoption in the clinical settings. And there is a very solid infrastructure, EMR, and most of the large hospital systems which are now introducing AI operations into their daily productions. The Asia Pacific regions is 25%. I'm just noticing that I got the percentages wrong on the map. So Asia Pacific market is actually 25%. Europe is 22%. The growth in Asia Pacific market is driven by the government investments. So think about vast populations here with very large healthcare systems. So particularly think about China and India. So these nations are trying to implement large-scale projects using public health managements, mostly early disease dissections, and they're trying to leverage AI tools to address some of the common healthcare AI challenges. And Europe comes in, third here with 22%. And so in Europe, there's a very strong emphasis on data privacy. And this is driven by regulations like GDPR. It's the same like HIPAA in the US, but it's a lot more strict and a lot more tight. And so they have a very strong emphasis on transparency, accountability, explainability from the AI systems. And so this is maybe slow down things, but maybe this is putting a solid background, and perhaps Europe will catch up later on. Time will tell. Okay. I'd like to go over some of the breakthrough moments in healthcare specifically. Some people may remember this MyCin system. This was a expert system developed at Stanford. And so you could put in information, it could diagnose bacterial infections and recommend antibiotics, and it performed at a level comparable to a medical specialist. Some of these other expert systems that came up in the 80s and 90s, people that maybe would have PDAs, you remember systems like Internist Eye or QMR, Quick Medical Reference. This was developed at Pittsburgh for internal medicine and diagnosis. Then Oncocin, that was also developed a standard trying to manage complex cancer chemotherapy protocols. DX Explain is another system that was developed at Harvard, MIT. But these MyCin and expert systems, they rely on extensive manual programming. And so you had to input the medical rules, and these systems did not have ability to learn from new cases. And so there is a breakthrough in 2011. You may have heard about IBM Watson, was a large language model who actually won the TV quiz called Jeopardy. And so it was remarkable to see the system that you just fed it a lot of data and beat a human in 2011. And another breakthrough was in 2016, where a deep learning neural network system, AlphaGo, won at this game. So this sparked again the increased interest. So all of this stuff is the past 10 years. Okay, I do want to spend a little bit extra time, a couple extra slides, learning about IBM Watson Health, because this has the rise and the fall of IBM system had sent a ripple to all of the future developments of AI. So if you don't know what this was, after the IBM Watson won the Jeopardy in 2011, it was considered to be a very good large language model, and it was just fed all of the cancer data. So this was sort of the hope that we're going to give the system all of the data, all of the knowledge, and this is going to fix cancer. And this would help the physicians in making the diagnosis and recommend the perfect treatment for the patients. And things just didn't work out quite it was planned. So why did it fail? The key challenges included data quality, integrations with hospital system, and a lack of clinical validation. So what happened is the system was fed a lot of what appeared to be like cases and not necessarily randomized controlled trials. So the system applied a lot of, if you will, case studies to situations that didn't quite match it. And it ended up producing failures. So, it was a famous collaboration attempt with MD Anderson, and that collaboration ended after about, a few months. And the system that started in 2013 was halted in 2017 after accumulating tremendous amount of cost. On the right side of this slide here, there's one of the news flash that came up. There's a publication by Ross and Svetlitz in 2018. Its title is IBM Watson recommend unsafe and incorrect cancer treatment in iStat News. So this ended up being a $4 billion investment in acquisition costs and R&D over approximately 7 years, which end up being shut down eventually. But we learned a lot of the things from this system. And again, the rise and fall of IBM Watson sort of sent ripple to the system, and is making all of us better these days, is what we're hoping. The major lessons learned is that we need to keep clinicians in the loop. So whenever you implement these solutions, you can't just throw a language model at it and just have it fed up information and spit out stuff backwards. It just doesn't work that way. And you have to integrate it with the EMRs. You have to ensure diversity in training the data. And once you have the system built, then you kind of start it small and make sure that it is clinically validated, whatever it produces, before you launch it at scale. So here we are talking about artificial intelligence. Why don't I let Dr. Gilmore tell us the official definition of this?
Yes. So artificial intelligence is essentially the study or the attempt to use computers to mimic human intelligence. And so this is broadly expanded over the initial definition of artificial intelligence. But processes include things like learning, reasoning, problem solving, perception, and language understanding. So many of us may have engaged with things like ChatGPT, for example. So you might have experienced the ability of this system to reason or to learn, and certainly to understand human language such as text. And so these systems are continuing to get better and better as they integrate with more users, and presumably become more intelligent. So AI systems really begin with data. So oftentimes, when you talk to AI engineers, the first questions that they ask are about the data. How much data do you have? What's the quality of that data? And because these systems are so needy for data, that's where a lot of the effort has been in applying these systems to healthcare. And that was actually one of the chief failures of IBM's implementation of AI in healthcare, was the lack or the lack of interoperability of data. Um, so these AI systems focus on processing this data, identifying patterns, and making predictions or recommendations that are either impossible for humans to recognize because they're so confounded by noise or other variables, or would be extremely costly or time yeah, costly in time or expense. So in healthcare, and specifically for this webinar, we're going to be talking about some applications that focus on processing medical literature, analyzing patient data, recognizing patterns in imaging, and I would add to that recognizing patterns in things like sensor data or clinical EMR data as well, and then supporting clinical decision making. But the key point for all of these areas is that there needs to be human oversight, or what's called human in the loop AI. So we need to have humans involved in the training and development of these applications, also in the validation for a particular context like healthcare, and in the continuous improvement. So we can go to the next slide.
So basically, AI is a monkey see, monkey do. It's trying to imitate human brain. That's a good way to put it. There's a few types of artificial intelligence out there. The three main types of narrow AI, general AI, and artificial super intelligence. So we are now in this first stage, narrow AI. Basically, all of the systems that you know of and you can name off as of today, they fit into this category. They are AI systems that are designed and then trained typically for a particular task. And this is the only AI that exists and is deployed across the various industry, including in healthcare. And the dominance of this narrow healthcare is very well documented. So examples in image recognitions for skin lesions. We do have validations, from a few years ago that image recognitions, they just as good as dermatologists in classifying skin conditions. Or we have tools that predict patient recognition. They can put all this data, can look at certain factors, age, risk problems, they can predict readmission risk. So all of these are what we call narrow AIs. The general AI is artificial general intelligence. This is, as of today, a hypothetical AI. As far as we know, And so this is a human-like intelligence that expands across a wide range of tasks and domains. And this has the ability to learn and apply knowledge flexible. And then the third category, the artificial super intelligence, this is truly hypothetical, and this is more like a um, speculative nature, and it's more like a philosophical principle. And this would be a type of intelligence that would exceed human intelligence in every conceivable aspect, including creativity, general wisdom, and problem solving. So that's like Skynet, right? But we're not there yet. We're pretty far. We're not sure if that's even possible. We're currently in a narrow AI category. And so the difference between regular computers and AI is the type of learning, is how these machines learn. That's the term, the machine learning. So in traditional programming, in some of the previous programs that we use so far, we have what we call the traditional programming. So this is where whoever creates these programs writes these rules. For example, if you talk about a wound, if you classify the wound as like 5 by 3 centimeters, then it should be severe. And so you have to program and write this every scenario. And there's thousands and thousands and millions of types of scenarios. And so it's limited by human rules and logic, and about a certain programmer or a group of programmers can foresee. And so he has very limited ability to adapt to new situations. It requires constant updates, and it cannot learn from new situations. And so what's different now is this machine learning. And in machine learning, as a principle, it enables the system to learn patterns directly from data without actually inputting these rules. You just show this data similar to like the way the babies learn. You just show them stuff, and they kind of like repetition, and they see things, and patterns get created. So you show one of these programs like thousands of images, and you can associate with outcomes. So then these algorithms can identify complex, simple. They identify correlations that are not obvious, that sometimes human may overlook. And so this adaptability makes these machine learning powerful and dynamic. And usually a programming approach in a standard way, it gives you an output, but a machine learning approach, it gives you prediction or data. So the main difference between these two is like the way that images, the way the stuff is learned. And the AI algorithm, they learn in three main ways. There's supervised learning, unsupervised learning, and then reinforced learning. In a supervised learning, the AI is given labeled data. So you show it images, and you tell the program what it is. This is a wound, this is a venous ulcer, this is a stage. You kind of just tell it, you give it the labels. In unsupervised learning, you don't. You just give it a data, and the program just looks at it over and over and looks at a million data points and kind of learns this and finds this pattern on its own. And so then there is also the concept of reinforced learning, which is sort of like a hybrid. You show it, you give it a lot of stuff, and then at some point you give it input. So there's probably thousands of people now in the world, in the country, that actually have as a job learning AI, training AI systems. They're giving pictures, and the program is showing them pictures, and they put it, this is a house, this is a horse, this is a white horse, things like that. So whenever you look at one of these programs, it's important to figure out how the program has learned the data.
And Luke, just a quick interjection.
Yes,
This is
sir.
um, one of the ways that you all have probably engaged with this without knowing is how many of us have used the CAPTCHA verification, like human verification system on websites. You know how you have to type in, the text or the numbers or whatever it is. So a real quick story about that. That was actually developed by a graduate student who was working in a languages department, and he was trying to, it was a really, really old text, right? And he was trying to figure out what the actual characters were, but there were obviously thousands and thousands of characters. And so he went through and clipped all of the characters, and he made this website called CAPTCHA and had people label what the characters were. And so he actually turned that, of course, into a multi-million dollar business. But we are all helping to train that AI by labeling every time you enter in and try to verify that you're a human, you're actually labeling that data set, which helps the model to improve itself. So there's all sorts of examples like that. But that, that's one of the examples that we're kind of talking about here today.
That's a very cool story. And so like tons of bits of data is like how the system learns. And then there's algorithms out there that each of these AI tools uses, and that's something that we as users should be aware. So I don't think I can explain this, but just at the very high level, and the graphical description sort of is very helpful to understand. Like neural network is you have the input layer, and then you have a bunch of hidden layers here where you don't exactly know where things are happening. And this is a we're going to come back to explainability. This is where the problem comes into place in here. Then once this goes to the system, it comes as an output. So that's the anatomy of a neural network and a deep learning. In the natural language program, this is designed for to understanding human language. So an NLP takes unstructured conversation and turns it into information. It puts into tables that you can create a note or things like that. The decision tree and random forest, this is probably the easiest one to understand. It's just a lot of questions, a lot of parameters, and it kind of takes you on a road. You kind of like have road signs. It's kind of like directions. So this is a model, the type of model that is more easy to understand because of more transparent decision-making process and easier clinical interpretation. And then support vector machines. This is based on statistical learning theory. And so this is easy to understand for people who have solid understanding in statistics. This finds the optimal separating hyperplane, maximizing the margin between classes. So this has better availability and useful for certain diseases and where things are not quite as clear. So talking about the common pitfalls and common errors when you look at these systems, the old junk in, junk out. Okay, if the system has poor data, it will produce poor outcomes because it learns bad habits. The same things that if kids learn bad habits, they will behave bad later on in life. That's the same thing as these AI models. We've already hinted about the black box problem. Data goes in there and gets bouncing between these different layers, and you don't know exactly how the system comes to that decisions. And it can, if it takes a narrow conclusion and it turns into generalizable conclusions, that's the automation bias. And sometimes gives you input that sounds good, and then you just accept it. And then if a user accepts these sound good inputs, then the system takes them like, oh, this is good enough. So it's going to continue to give you these bad outputs. And that's what creates this automation bias. And then, of course, the ethical and regulatory hurdles. We're very concerned about HIPAA, about privacy. If you put patient information into this system, where does it go? How long does it stay there? What happens to it? So this is a critical, important aspect to consider when we look at these AI models. And I just want to expand a little more on the concept of explainability associated with this black box model. This is getting a lot of theoretical papers and is getting a lot of attentions. The lack of transparency on how the models produce the outcomes. And if you don't have a good way to explain the outcome, This can hinder trust. It will defer the clinical validations and the treatment recommendation that you can produce. Hallucination is another phenomenon. The system just makes up stuff. It just random makes up things or so. It probably has some of these models have access to internet, and on internet there's all kinds of things out there. Not all of them are real. Basically, like fake news. That's what hallucinations are. Fake news. And this can be a problem because obviously, if it's not tied to the reality, it's incorrect. And then algorithmic bias, I've kind of explained that already. There are a number of medical fields where AI models have reached really solid validations. So this is widely used in radiology, in imaging. There's FDA validations of different type of software. They can read CT scans, they can read X-rays, and the performance of these systems are at the same level with radiology. In ophthalmology, the Google AI system, you can show it the pictures of the fundus of an eye, and you can recognize a retinopathy or so. So this is widely used and validated in areas where access to ophthalmologists is limited. And probably a lot of the listeners tonight already are wearing a watch. They're kind of watching their heart rate right now. So there's a lot of validation about this already. And then pathology also has a significant amount of validation as well, looking at slides. We expect AI to help us in medicine in these four main type of categories. You give it the patient information, you give it the data, and then based on that patient, it is supposed to help you with the clinical decision, help you reach the diagnosis, and then helps you make the recommendations that are based on the guidelines. Because we forget a lot of times to do the guidelines, like check arterial studies, follow this. These are the things that you would hope that AI models will help you do. The administrative tasks like patient rescheduling and sending letters and the flow of information, gathering the relevant patient information that you need to make these recommendations. Predictive analytics is something that AI models excel because they can take a lot of data that it's hard for humans' brains to take into consideration at the same time, and that's the same reason they work in drug discovery and development. So as example, I've put here a couple of AI models that I'm familiar with. For example, AVO AMD. This is AI tools that is a language model. It has a significant amount of clinical guidelines, and you can go there and ask them to help you read and make sense of the clinical guidelines, or you can put a clinical case scenario in. I have 47-year-old diabetic foot ulcer located in plantar surface, and what should I do? And it tells you, check your arterial studies, consider offloading, make sure that sugar. So it tells you this recommendation based on the guidelines. And Google Notebook is a collaborative, free, accessible resource. You can put in there information. You can control where the system gets its information. So I use this, for example, right now in collaboration with wound care collaborative community. We have a project we're trying to figure out some standards of care. So we put into this Google Notebook all of the guidelines that we can find out about standard of care, and we try to make sense of them, but we couldn't as clinicians to come to streamline conclusions. And the system is spitting out some standard of care broad across some categories. And now we're trying to create a Delphi process to validate this recommendation. So that's some interesting work that's going on in the background here. In wound care specifically, we've seen quite a significant rise of AI applications in wound measurements and tissue type classifications. So I'll let Jordon speak about this.
Okay. And we only have about 10 minutes left, so I'm gonna go pretty quickly. But if you have any questions about these, then I'll be happy to answer during Q&A. So the topics that we're gonna look at are applications of LLMs, image-based chronic wound diagnosis, predictive modeling and forecasting, remote patient monitoring, and telehealth or virtual reality, patient engagement coaching, things like that. So we can go to the next slide. Large language models. I wanted to start here because this is something that we probably all heard about or maybe even tried. It's really made AI accessible to lots of people. So these models, like we said, are trained on lots of data, primarily from the internet. But in some specialized cases, there are large language models that are trained specifically on particular context, such as healthcare, such as what Dr. Vlad was just talking about with Google Notebook with a particular group of literature or standards. Within wound care, these models are being used to do literature reviews, to put out patient education and content development. And I have an example on the next slide of that, and also summarizing and structuring clinical notes. Um, so go back a slide, please. Okay, I'll come back to it. Go ahead. You can go forward.
Yeah.
Okay. Yeah, that's good. Now I wanted to highlight some of the image-based chronic wound diagnostic tools. So why images are, I think, are a really accessible point for AI in healthcare is that clinicians, and especially in wound care, are already used to looking at images, are already used to making clinical decisions based on visual inspection. So that's one of the major advantages of image-based systems. They are inherently explainable because people kind of understand the images, right? Image recognition has been around for a really long time. It's already being used in things like X-ray, CT, MRI, and ultrasound. So the picture that you see on the right is from a paper where they are actually trying to develop a training set for detecting osteomyelitis in diabetic foot wounds. And so you can see there's examples here, but in number 6, I wanted to draw your attention to that. It's a blank image. Why is that there? That's there because it's important for the model to learn what the background is, right? So you have to have both good examples and bad examples so that the model can really understand the totality of the picture. When we look at these images, we can clearly see that that's a foot or that's an x-ray of a foot, even. But the model has to learn all of these things from scratch. So it's important to have many, many examples, thousands of examples that are extremely diverse so that the model can make accurate classifications. More tasks related to images are computer vision. So things like making measurements, image classification, like I just talked about, and then image processing. So cleaning images. One of the big challenges that we have in wound care right now is developing large image data sets that are free and open for researchers and clinicians to use for developing applications. So this is something that's happened already in radiology, in other imaging modalities. There are these large open source data sets that make it really easy to train models, and so we need to move forward in developing some of these data sets as well in wound care. You can go to the next one. Um,
We're talking
go
about
ahead.
the predictive analytics, and so in wound care, we're hoping that this predictive analytics will help us get a fast understanding of the healing time, outcome forecasting, infection risk assessment, and treatment optimization.
An example of that predictive modeling and forecasting is this image that you see here on the right. This is from a paper where they're building out a structural equation model. And what I want you to notice here is that the data represented here in all of these boxes is multimodal. Um, and so there's data that you would collect through imaging, there's data that you would collect through other sorts of clinical tests and measurements. There are also data that you would derive from the EHR. So all of these can be distilled down into variables that a predictive model could use, right? So all of these things are important, but you'll notice on the list over there on the left, it says patient history and demographics and social determinants of health. And I've got asterisks beside those. The reason why is because you have to think about the ethical issues and bias that can come with including some issues like that, right? Like for example, if you've got only a few examples in your data set of patients with darker skin, and all of those have amputations in them, your model may make the assumption that if darker skin is associated with amputation, right? Which is a biased interpretation of the data, right? So it's important to think about those things as we build out these models. Also, thinking about explainability and interpretability, which I'll cover on the next slide. On the figure here on the right is a Shapley violin plot. This is a very common type of explainable AI approach. So when you have things like neural networks, which Dr. Vlad talked about being really complex, and you don't really understand where the data is coming from, we can do kind of post hoc explanations, right? So we can put things on top of our models to give us insight about how the models make decisions. So in this example, this is from a paper where the authors were trying to determine a predictive model for whether a patient's wound would heal in after 4 weeks or not. And so they have all of these variables that you see on the left: days wound on service, wound depth, etc., etc. And as you go down the list, you could see that the feature value, which you see on the right, going from high to low, that represents the importance of that variable to the algorithmic decision. So to that output decision. We also have a SHAP value, which is on the x-axis there, going from -6 to +2. So what that's displaying is what the directionality, right? So for example, if for the first variable, days wound on service, right? So that's saying that the more negative that value is, the less likely the patient is to heal within 4 weeks. So we can get a great amount of insight from adding these sorts of explainable algorithms on top of our AI approaches. So other ways that predictive modeling could be used are in areas like risk stratification, right? So you could categorize patients or based on variables that you see, which could influence patient communication, treatment, and long-term planning, or even site analytics. So that administrative piece that Dr. Vlad talked about. We can go to the next one. Here's that example of the large language model slide I was talking about. So here, just quickly, you can see that this is a flyer that I just made quickly in preparation for this. I just put these two prompts into ChatGPT. So create a flyer for self-care diabetic foot ulcers with key components of care and safety. And then I even put a design element in there in shades of green. So notice that I didn't actually describe what the key components of care were, right? The model actually came up with this on its own, and you all can read that. I think it is fairly reasonable, but you all can read it and maybe tweak it and make some suggestions. But then you can add some things, right? So that's it. I add an image of a happy but overweight person, getting a foot exam. So those sorts of things, right? So we can do this. We can create images actually in content with these large language models as well.
That's a pretty good example there.
So this paper highlights how we can use LLMs to actually analyze the literature, right? So I'll quickly go through this one. This paper analyzed tons of keywords and split them out into these clusters. So this is an example of an unsupervised approach where you can see how the clusters are split out by color. Then we could use these authors use a GPT to assign actual labels and values to the clusters. And the outcome from this was that they were able to pull out some thematic things from the literature concerning um, biomaterials and wound dressings. So we can go to the next one. Remote patient monitoring. This is something for those of you that are engaged in clinical work. This is something that I'm sure that you've been exposed to. Remote patient monitoring platforms, we're including in this talk because they are enabling us to collect continuous data, right? And we need data to facilitate these AI algorithms, right? So these devices can communicate with providers and give just-in-time information. It can do things like compliance checks. For example, we have a negative pressure wound therapy device here that we can have patient support, compliance checks, interaction. We can check on healing progression, do things like detect infection. Um, and a lot of these remote patient monitoring devices have focused on having patients and caregivers provide data to the clinic, such as collecting images. So you all have probably seen some of these where it's like a phone app where the patient can take a picture of their own wound and then send it into the clinic. So these types of technologies are actually building into the future AI applications in wound care. So next slide. Here are some examples of remote patient monitoring in the literature, and I also have a review article down here if you're interested as well. So in this particular study, we have in the middle column here, we have an AI medical device, and it's trying to make a classification and give a percentage of necrotic tissue based on a particular image, and this is compared with a physician's evaluation as well. And why these things are important is because if we're going to have devices that are collecting images and then trying to make diagnostic decisions, we want to know if those decisions are actually valid or not, right? And so these types of approaches have actually been shown to improve clinical outcomes. In one paper, they showed that digital tracking, so having a patient engage with their mobile phone with taking pictures and I'm sending those pictures to the clinic. That was actually associated with shorter healing duration, 15 days for using digital tracking versus 35 days for not. And then also, digital tracking was associated with fewer nursing visits. So some real positive outcomes from that paper. Then the next slide. Oh, go ahead, Dr. Vlad.
Some more examples of remote monitoring. Diabetic feet. Patients can feel their feet, so they tend to, cause, unintentional damage, loss of protective sensation. So a number of devices out there, they're kind of trying to make up, different kinds of mats, thermal monitoring. So I just kind of throw some example. Patient steps on a mat, and this measures pressure points and measures temperature. A wound on the first AMT, the tissue is going to break, is going to increase temperature first before it's going to break down. So if you see an increase in temperature from day to day, it's going to send alert to the provider. Or, different same principles with socks or other types of foot scanners or even inserts. They have pressure and temperature sensors, and they have the data displaying on a monitor. Or how about a boot that has a smart sensors? And the boot is connected to a watch that sends patient prompts like, hey, I'm happy you wear your boot. Why did you take your boot off? Put a boot on. And it reports all of this compliance data back to the provider.
And then wrapping up here, we have things like virtual reality being used for pain management and also for education and training for patients, trying to engage them both inside the clinic and outside. Things like using AI conversational agents like Siri to do coaching. So there's lots of things that we use every day that are making their way into clinical practice.
So what we're hoping to get from these tools is real-time guidance. We do hope that they're going to give us personalized protocols and predictive preventions, and this is going to be integrated with our EHR and actually do the clinical notes for us as well, right? Yeah. So AI is not about replacing the clinicians, but it's about empowering them to have better tools to provide more precise, efficient, and effective care. And if you're thinking about implementing this into your practice, some things to consider here. You have to assess your current flow. Don't go all in. Start with some simple tools, train your team, and then, like a lot of PDA projects, measure the impact of that tool, refine it, and then kind of like take it from there. And we do have here a couple of slides with references. Some of them are selective in case anybody wants to kind of track some of these references further. So we can start a Q&A session. And if anybody has any questions, you can type them into the chat, or we were also looking, while everybody is thinking about questions, we'd like to solicit some input about future topics and what topics would be of interest, and try to find the appropriate speakers, probably a higher level than I am, and not just the basics, to go into more details of an appropriate use of some of these AI tools.
Mohammed, I can't hear you if you're speaking.
Hey, yeah, you are muted. No, you're not.
It says you're unmuted, but I can't hear you.
I can't hear you either. Let's see. I guess if anybody has any questions, you can go ahead and put those into the chat or the Q&A, and we can take them from there. While everybody's thinking about this,
Can you hear me now?
yeah, we can hear now.
Oh, perfect. Thank you. Sorry for this glitch. And I was like just wanted to thank you, both our speakers, Dr. Vlad and Dr. Gilmore, for this wonderful talk and this insightful and forward-looking discussion on artificial intelligence in wound care, as we have explored the evolution of the AI, its current application across the wound care field, and the exciting innovation shaping this future, from the predictive analytics and the remote monitoring to smart devices and large language models. As we have seen, AI is not here to replace clinicians. That's what we want to emphasize on, but to empower them with tools that enhance precision, efficiency, and patient outcomes. And as we are waiting for the questions, if anyone wants to ask or get clarification for any of the content, I have some questions for our speakers. I would like to start with how can we ensure that the AI models used in the wound care are trained on diverse and representative data sets to avoid algorithmic bias and promote equitable outcomes across patient populations? So if I have a tool already available in the market, how can I make sure that these tools were validated in a proper way? Dr. Vlad can start, and if something coming, Dr. Gilmore can comment as well.
Sure.
I can take a jab at this. I think an important thing to consider is scalability. So, we're kind of used in research to do power calculations. Yeah, I think we just need to sort of do similar calculations when we figure out the size of the data sets. But I want to sort of throw this blanket statement out that the larger the data set, probably the more diverse it is. So just simple logic out there. But I guess anytime we train a tool, I think is the responsibility of the team that does the training and selection of those to make sure that it's a representative population. So, like example, Dr. Gilmore brought in, you want to study venous leg ulcers, you have to look at all of the skin tones. You have to put the background in and no, don't study just a certain subset of a patient population there. So I think that's sort of like a basic thing that we do in a lot of our randomized control trials. You try to look at the population and is that representative. So a similar thing that we have to do with the model that we give to the AI tools.
And I would just add that I think wound healing presents a unique challenge when you think about other clinical areas where imaging has been used in AI because the images that we usually have in wound care are not like nice clean x-rays where you're going to have the same background every time. And most of the images that I've seen, they're happening in a room, right? And so there's going to be a bed in the background, or there might be someone holding up like a scale or a measurement tool beside the wound, or there might be a caregiver in the background. So all of these things will actually affect the performance of the model. So as we're thinking about building out data sets, it's important to think about kind of standardizing how the images are acquired. But when that's not possible, it just increases the amount of images that are necessary. And then thinking about things like patient diversity, thinking about you know points of potential bias. And then the last thing I'll say is one of the new things that we're seeing is generative AI approaches. So the way that generative AI is kind of the basis of large language models, right? Where an AI will take an input and it will generate text back to you. And the idea is that there's there's dialogue between the user and the AI so that it can iterate and improve its outcome. So what people have done in those generative approaches is they try to create their own data, right? So let's say I have 10 wound images, but I really need 30 images to train my model. There are lots of algorithms out there that will allow you to make small perturbations to those original 10 so that you can create 30 different images, right? And so this is called synthetic data, right? So those extra 20 images are not actually real images, but they're very similar to real images, and they can be used for training in many cases. The challenge is that you can't have more simulated data than you have real data, right? And so there are all of these different types of things that we have to think about as we're trying to create these data sets and then use them and validate them on different patient populations.
And these are the things considered when you validate any of these models.
Yeah, thank, thank you very much for your comment on this question. And I think in 1 minute, so what do you think, what are the strategies do we recommend to ensure clinicians maintain trust in the artificial intelligence tools when they are using this, even in wound care or any other like platforms?
I personally think that any AI tool should or any clinical decision that comes from an AI tool should be connected back to a clinically validated measure that clinicians are used to using. So in my research lab, for example, we always try to connect our sensor data back to images, all right, because we know that clinicians understand images, um, and they can look at a wound and generally understand
Yeah.
what's going on. So that's my personal opinion that we can have all of the fancy explainable algorithms and things like the Shapley plot that I showed, but ultimately it should connect back to something that people are used to interacting with on a day-to-day basis.
I think you illustrated that on that side, Dr. Gilmore, like you showed the features that are important into the input to, I think that's the key to it. So just make that visible in the model, which is the important stuff when the decision is made.
Yeah, that was wonderful webinar and discussion as well, and it is very interesting topic that we will have like another series of these webinars going forward, and especially in the debates on the AI ethics and how to use them in your practice, how to judge them when you are using them. All of those will be coming in future webinars. And I would like to thank our speakers today, Dr. Lucian Vlad and Dr. Jordon Gilmore, and the Wound Healing Society for this wonderful series. And thank you all for attending our AI webinar brought to you by the WHS Education Committee and Wound Healing U. As a reminder, the recording will be available in your member-only account on the Wound Healing U and the WHS YouTube website in the next few weeks. And also we have in the next few months, we will have so many different webinars on wound care basics, difficult to heal chronic wounds, lymphedema, and burns. Please look out for those announcements. And at the end, I would like to thank you again and have a wonderful evening.